Well, thank you very much for this update. And I'm hearing the cath lab is ready, so we can go back to Prakash.
Hi, Dirk. How are you? Great lectures. We had a lot of pleasure here listening in while we were trying to get this case ready. So without further ado, we're going to go ahead and present it. You guys know the team.
Okay. So good afternoon, everybody. So this is the last case from Mount Sinai. We have a 68-year-old man, again, multiple classical risk factors, hypertensive, diabetic, and an ex-smoker, 1 pack a day, dyslipidemia, high LDLs running in the range of 150 to 200. He presented to us with the left leg pain for 2 months, which was more at night, very typical for rest pain. And he developed an ulcer for 2 weeks ago. It's on the distal aspect of the first toe on the plantar and distal and plantar aspect of the first toe. We had the ABIs from outside, which were right was 0.62 and left was 0.33. And he was referred to us with a reported history that he had an attempted AT angioplasty, which was unsuccessful. We did a duplex here, which was suggestive of bilateral AT and PT occlusions and ankle pressures. We didn't do the full ABIs, but we had ankle pressures of 28. Nothing remarkable on the labs, creatinine 1.1, and he's on appropriate medical management for his PAD.
So when you look at the angiogram, it looks like he's had some work done in the past. His iliac showed nothing. We have the outside picture of that. The inflow in the SFA looks okay. And if you look down below, his distal SFA also has mild disease. I'm sorry, no, just hang on. It has mild disease as well in the distal. But then when you get down into the infrapopliteal, he looks like he has a DES in the proximal. He has basically subtotal occlusions of his anterior tibial artery, and posterior tibial artery is totally occluded. He also has a perineal artery that's diseased. And then as you come down into the foot, he has a subtotal occlusion of his AT. And then you can see here, very, very slow filling. And then he has disease in the dorsalis pedis as well in the foot, with posterior tibial not really being seen. So at this stage, I think that the problem with him is he has very severe disease, with the perineal artery being the dominant flow, filling first, with very significant disease both in the AT and the PT. The PT seems to be filling via collaterals from the perineal, as you can see in that injection right there. But I don't know if that's an unnamed, is that a named or unnamed branch at this stage. So at this stage, so what our plan is going to be is, what we did was, while we were offline, we went ahead and put a catheter in the perineal just to try to see what the flow is to the foot through the perineal vessel. So we have a catheter at the level of the perineal now. And what we're going to do is we're just going to inject some dye. Put me on DSA, guys.
PK, as you do that, would you mind making me trying to do a little bit more of a lateral projection?
Sure.
Because I'm also confused about the anatomy, but I think part of it is the projection of the II.
It's very confusing. I agree with you. We were looking at this. Here's a sir. Try not to move the foot. Okay.
First it.
Ready? Inject. And you'll see, Miguel, that DP is quite diseased. See, the perineal fills first. There's your AT coming in slowly. And then the posterior tibial comes in at the end, but it looks like all collateralizations. And I don't know if the toe is going to get enough blood from just that anterior tibial artery, since it's also involving the plantar aspect. And angiosomally, I think you're going to need that posterior tibial. The question is that a true posterior tibial, or is that just a total all bunch of unnamed collaterals that are sort of forming that particular area?
I personally think if you get the forefoot in that image and that arch is at class 2A, meaning it's being fed from the anterior tibial, and you see that there's a blush distally into that first toe, I would feel very comfortable not necessarily going after this.
What is this thing in the
EKG.
Can you move the EKG lead, guys, for us?
No.
Carefully.
So yeah, I would feel comfortable just focusing on the anterior tibial. There's too many small, squiggly collaterals. There's no nice plantar. It may not be there, or it may light up.
Don't move, sir.
once you get the AT open in a retrograde fashion, it may be that it highlights. So, I think I would not have concerns in just going for the AT initially.
Let me just take a picture now. We've got EKG lead out of the way. Again, he's uncomfortable. Let's see here. Sir, try not to move. See, Miguel, it's not a robust flow at all, and you can see it's a very, very poor arch. I'm gonna try to cross the AT then first, and then get a better shot from below. But how would you guys treat this? Let me do the perineal picture first to see whether we see anything on this side, and then we'll come back to this in a second. Because I always believe like the perineal is the lifeline of the foot, the left main of the foot, and the lower extremity. So let's see whether we're getting anything through here. So this is selective perineal injection.
Okay, little boss.
No, don't move.
There you go. One more picture, guys.
Yes.
I mean, this is one of the challenges when you have such extensive disease, you really don't have, you're not certain whether you have any named arteries here or not. And you can see it's a very poor filling of the distal foot through the perineal artery, and what I'm assuming is going to be just unnamed collateral. So his entire vessel is really living off that anterior tibial. Mm-hmm. So the question here is, in terms of therapy, it looks like he's had a proximal DES at some point. I'm just going to pull this back here and wire this, and I'm going to take a selective picture. Can I have now what are the different wires you guys use to get through these subtotal, total lesions? Hydrophilic wire, guys?
Probably the workhorse that we use on a daily basis is a Command and the Command ES. Those are Abbott wires that have, in a way, they have nitinol cores. So after being a PT2, PT graphics guy for many years, but you'd go through 4 or 5 of them in a case. Now with a Command, you could actually get 1 Command or 2 to get you through a really complex case. So that would be my first option.
Yeah, PK is George. I tend to use stepwise progression with some of the coronary wires, but I agree with Miguel on at some point switching over to the Command. I had a question for you. I don't know if I was hallucinating or not, but is there another stent down towards the ankle, or is it just this proximal one?
I'm sorry?
I thought I saw something down towards the ankle. Is the DES proximally, is that the only one, or is there another one further downstream?
I actually have not seen that. When we get selective, let's take a look. They might be, as I said, he has had work done before.
I also have the impression that
I saw one down near the ankle.
I
think there's one though.
So he had a drug-eluting stent in there?
He did. This looks like either a Xience or this is a Xience. Yeah, this is a Xience stent.
Do we know anything on timing, how long it's been there?
Yeah.
Definitely this has been probably in the last year.
Okay.
For this same ulcer?
Oh, no, this is new.
So he got this treatment for below the knee arteries just for claudication?
No. I'm certain at that time this must have healed, and now this is reformed in this particular area.
Okay.
So it's very migratory over here, Marianne, and that's the problem a lot of times. Sahil would tell you, we have, I'm sure we share a lot of the patients that go here and there. And, this is the issue, and a lot of times our colleagues, and then the history that we get here is very different. So the takeoff is a little odd here. I'm just going to make a better curve on my wire. I think the problem with the Command at times is the curve tends to fall off and then doesn't do it. So let me see. I'm going to need a better curve.
Yeah, that's why I like to start with the coronary wires. I just find they're easier to maneuver.
They are, but this wire has become part of our workhorse, and we've been able to do it most of the time. But for some reason, with this arch is also very tortuous, we haven't been able to had a lot of trouble getting up and over because of his tortuosity. And a lot of times, the transmission of the torque, when you have such a tortuous arch, really makes it easier for an antegrade stick. He moves around quite a bit, as you see, so we were a little hesitant to go antegrade at this stage. So I'm just going to go back in with a more bolder tip here. and then we'll see.
PK, that wire is a little hard to shape. What I do, I can't see if that's what you were doing as well. I put it through a dilator of a sheath, and then I fold my finger over the top of it as I sort of strip the wire, so to speak. Is that what you do?
Brian, do you find that at times with this wire, what happens is, Ray, can you hold the catheter? But at this time, when you put it through the sheath, it again straightens out again? Torquer?
Not so much if you put a good curve on it. I really haven't had that issue as much as making that initial shape that I want.
There it goes.
Looks like you got it, though.
All right, looks like we got lucky there. So I'm just going to take this down and take a selective picture from within the stent. There you go. Let's take a selective shot here and get an idea. Because I think, the idea is how can we give a durable therapy? He's had DES, he's restenosing and also reblocking in the proximal aspect of this, and then he's having skin breakdown. So low mag, guys. So focal, diffuse, come down. Right there. I think you're right. I do see it now. There is one there.
Yeah.
Yeah.
Very diffuse there. And then at the level of the stent, it looks like there's some ISR. Now show me the foot. Can I have this a little more dye, please, in this syringe? And I think for the audience, this type of selective injections also helps. Let me see whether we can see the forefoot. Oh, sorry about that.
Forefoot and a lateral view if possible.
Yeah, that's what I'm going to do now.
I know I'm being needy.
No, I do the same thing. Try, sir, just
Come
try.
off mag, yeah. There you go. Look at that. Beautiful.
There you go. Try not
look
to
at
move,
that.
sir. Wow. See, you can see that's the problem with that area where he's got the wound. The issue is going to be how, is this opening just this up going to be able to get enough flow down there to be able to heal this? The question is also whether once we open this up, whether the pressure head will increase and then allow us to get a better visualization to see whether we can form the arch as well. So at this stage, I'm just going to wire this, and then I'm going to just want to ask you guys to comment on how you would treat this, and then how you would deal with this distal disease that he's having.
PK, I think this does not sound like a huge ulcer. I mean, it sounds like something that has just reemerged due to restenosis. There are some critical lesions in that AT. I would favor just doing that. I don't disagree with seeing what the foot looks like, how much of the arch lights up after you do that, but I'm suspicious you won't see much more than you're seeing there.
But Brian, I mean, in the sense, for preventive measures, I mean, it's a very good patient, does foot care, follows up with the podiatrist, all that stuff. I mean, the reason he keeps breaking down is clearly, he has ischemia. So I mean, when do you start to get aggressive to go after these distal vessels? I mean, healing the wound is one thing, but if we get a more durable result and if we're able to open up distally, do you think that would help prevent any further alteration here?
I mean, I personally, I wouldn't open up a pedal loop to try to prevent future ulcers. I think you do that when you have to get something to heal. There's always the chance that you'll shut down the digital metatarsal branches as you go after the pedal loop. So you can always make these worse, and that's why I would fix the problem at hand. And I'm not sure that going into the foot's going to change your longevity of that proximal intervention.
And in terms of therapy?
Well, I wish we had DCBs for this because this is clearly one of his problems, but I would probably do atherectomy and angioplasty. It's interesting that stent down at the lower leg there. The distal third. All the surgeons who've done fasciotomies know that this area right where you are now with the wire is where all of these muscles are very tightly, constricted by the fascial compartments, and it's an area where you'd expect to see stent fractures or crushing of the stent.
So now I've gotten the transit catheter into the foot. So I want to take a DSA in the same projection. Can I have some vasodilators, please?
50.
So I'm going to give some nipride into the foot. And I think this is also another important thing that we do a lot. We just give a lot of nipride to be able to see what's going on. Let me see. So this is 100 mics per cc, guys?
Yes.
1250 mics per cc, and how many cc's? 4 cc's?
So PK, this all goes into the discussion that you and I have had multiple times about not really having an objective performance goal for determining what amount of perfusion you have. So here is where, maybe a methylene blue injection that goes straight into the toe would help you decide that you're fine.
Right.
Here's where a micro-oxygen sensor at the base of the first toe that shows an increase of whatever, times 4 oxygen content within and after your procedure, and so on and so forth. I see that, I call it a day. I mean, open the AT and run away. Look at those digital arteries on the first toe. They look beautiful and plump. I'm not sure that you could do quite more by trying to loop around. I mean, it may look sexy, but it potentially may not accomplish the end goal, which is to try to keep him open for a longer time.
I agree with you. I think at this stage, having taken that picture, I feel a hell of a lot better with doing what we decided to do. But as far as durability, interestingly, the drug-eluting stents are open.
The DESs look great.
Yeah. So the question is, that's what I want to ask you. So what would you guys do in terms of trying to, would you use a whole bunch of DESs here to keep this open, or how would you deal with this?
Well, PK, I like to use DES below the knee as much as the next guy, but I think it's a pretty long area. I'm not totally sure that, stacking 4 or 5 of these in a row is going to be a great idea, but, we are a little bit hamstrung in the sense that we don't have DCB. So, I mean, if you're going to do the best that you can in the United States, I mean, I kind of agree with Brian. You may want to give atherectomy and maybe an IVUS-guided PTA, just so you size it and do the best possible job you can with that. And then at that point, maybe spot stent if you have to, but I don't know about, 150 millimeters of DES.
How about you, Marianne, in terms of what do you guys do? I know you have a lot more available in Europe in terms of your ability to treat these kind of lesions. What do we do? Because in America, we're stuck with atherectomy, balloon, and cutting balloon. That's pretty much what we have.
I mean, we would do atherectomy it depends if atherectomy is reimbursed, so this is not homogeneous in Europe. But anyway, at our institution, we would do atherectomy and then we will use DCP because you see that the drug-eluting stents are open, so I think drug might work in this patient, and we would use a DCP, and if we have an issue with dissections, we would maybe do this so-called spot stenting, and you can say you go for this philosophy of just use the bare metal stent after TCP usage.
Or the TAC.
TAC.
Okay. So the DCBs you currently have available in Europe, is there any difference in performance among them, or do you feel that they all are pretty much the same?
I mean, we have the Lutonix, we have the Stellarix balloon in the meantime available for below the knee usage. We have the Biotronic balloon, and I mean, concerning the data for above the knee, which is promising for the Stellarix trial, and also for the profile of this balloon, we use a lot the below the knee Stellarix balloon because we can use it right now. We have it on the shelf.
So I'm going to do what Brian suggested. Is what we're going to do is a directional atherectomy of this. I think as much as can you show me going through the stent, guys? Thank you. Okay. Thank you. And one of the things here is you got to be careful as you go through the stent, just to make sure that you don't have any issues. So we're just going to get down away. Let me show me above.
What kind of atherectomy? Maybe I didn't hear that.
Turbo.
This is the Turbo Hawk. Go ahead, turn it on. So we're just going to make 2 passes here very, very slowly.
It was from what to what? It was like 12 to like 18? Or
12 to 20 is what I was thinking.
20. Okay.
And then come back. This is the tightest spot pretty much. And then come back and take a look, see.
Slow cowboy.
Is that an SXC?
It's an SXE off. It's very aggressive, as you know, Brian. I know that everybody wants more aggressive cutters, but I get very wary when they're so aggressive below the knee. And especially mag up, please, at this area. Yep, go now. Yep, that's good, go. So I try to do 2 passes, 1 in each zone and 1 in each angle off. And then when there's rotation of the cutter, I try to rotate it back into the medial plane where I want to look at it. What you have to be careful about is wire wrap on. because as you keep pushing this, the wire will wrap and will get you in trouble. Show me down, guys. And then go slowly down to about 20. Off.
So we were discussing before about this food
Low back.
situation, and do you not fear that there is any issue with the atherectomy system in such a patient, that you have, distal embolization or whatever? Because this is always the argument of people who vote against atherectomy.
You
Just have to be careful.
I don't think the problem is, filters haven't really been effective in terms of below the knee. So, we really don't use filters below the knee. I think it's the technique of atherectomy that's very, very important. Really slow passes. I'm more actually, try not to move, sir. I'm more actually worried about perforation in these kind of repeat interventions, because of the actual flow. Now that's much better. But I really believe that debulking does help us in terms of getting patency. Jim McKinsey's data from the definitive LE series is probably some of the most compelling data below the knee outside the DES, even though it's registry data and it's not a randomized controlled study. See, when the lesion looks like this, Marianne, this far down, like especially from 20 to 30, I tend just to make one pass rather than two, because I believe that that's an area that I'm positive has been worked on before, and that's probably multiple areas of dissection. So I worry about that perforating. So I'm going to just go with one pass from 20 to 30, and then do a prolonged balloon, or even a chocolate balloon at that stage. The reimbursement issues are real, but at the same time, I do not want to put a DES down here for all the reasons that George said. I mean, unless we come up with a nice self-expanding DES, it would be nice. But here you're going to have to put 4 or 5 or 6 of these DESs, which is something we really don't want to do.
Well, that's going to be an interesting discussion as the Saval study kicks off.
Right.
This is a self-expanding drug-eluting stent created for the below-the-knee application. It's a Boston Scientific technology. And it comes, from what I understand, in a length of up to 80 millimeters initially. So it'll be interesting to see what comes from that, because as appalling as that may sound to many surgeons, I would not hesitate to do that. If the results are fantastic, why not? Ultimately, you're not burning bridges of anything, because the distal bypass will go to the dorsalis pedis anyway in a situation like this already.
Mm-hmm. Show me down.
Down.
No, this is good. The interesting thing is, even though stenting is really not in favor for a lot of people, the data really shows that that's the best thing we really have in terms of what really is durable. I know that the restenosis always occurs proximal and distal to the stent, but the question is, if you look at what we're able to get out of it, it's really surprising. I want to ask Brian this question. Brian, when you cut these diffuse lesions, and I can tell you I'm kind of nervous here because of the look of that artery, do you cut in one direction, any one direction? Do you pick? I just want to show you the last picture. So you see here from 20 to 30, you can see that the lesion right there. So you can see it's multiple, lumpy, bumpy, but clearly it's significant along with the others. So the issue here is, do you pick a certain side, anterior, posterior, lateral, or medial to cut? Is there any algorithm or any thought process you use?
Well, I guess the couple concerns are, number one, because it's directional, you can focus it where you think the heaviest plaque burden is. So obviously I agree with pointing it toward the area that's more stenotic or has a heavier plaque burden. The other thing you need to think about, which is less relevant in the tibials than it is in the FemPop, is you want to start cutting opposite the wire bias. So if a wire is leaning on the medial side of the vessel, if you start cutting that medial side, you're going to be moving further and further away from that lateral side. So you want to cut opposite your wire bias. Not really an issue here, I don't think. I also agree with you in terms of limited number of cuts. I think the TurboHawk series does a very good job of debulking. I would be cautious about being too aggressive this far down, and also watching your nose cone as well. You want to make sure the nose cone isn't going past the wire at the ankle.
So I'm going to just do a cut from 20 to 30 here, very slowly, and and then we'll take a look. So, ready, guys? Let me see.
Brian, are you aware what the OD is on that particular catheter?
God, I'm not.
No.
It's I think it's F2 range.
I'm always asking myself, is there a degree of dottering
Give me the
here
nose
that's
cone.
just
Oh, yeah.
happening for this
Yeah, I think
bulky
I
thing
think
going down.
we definitely daughter with this. At the same time, dottering through helps you determine, excuse me, how easily it's going to pass, you know, and if it doesn't daughter easily.
So that's the nose cone right there, Brian. So we're able to reach all the way down. We've taken this catheter into the foot, you know, into the DP in the foot, the smaller version of it.
Yes.
It does work. I mean, you just have to be careful with it. And I definitely, I haven't had much embolization below the knee. I think above the knee with the bulk, with the volume of plaque, we've had more embolization. So that's been an issue. My worry here is exactly what I said, is perforation.
And to Marianne's point, I think that the embolization is a risk. It's a risk with every type of intervention we do. The atherectomy devices vary in the type of embolization, though, and so the good thing about TurboHawk and SilverHawk is that when you get emboli, they're things that you can see and you can retrieve, as opposed to some of the other devices where you get more smaller diffuse particles.
I guess it's a very important point, because we always think, you know, all the other devices are safe concerning embolization, but that's not the case.
Yeah. That looks nice, PK.
Yeah, no, I'm going to stop there with only one cut here, Brian, because of the whole entire aspect of perforation. I worry about it. I don't think the utility of IVUS is much here because it's such a small vessel, and I think intravascular ultrasound is really not going to answer us a question whether the plaque has been adequately debulked here. My goal of debulking with this particular lesion, and I think that would have been a good question, why not just balloon from the beginning, is really, honestly, to prevent stenting. I think that, you know, the only thing that we all can say that atherectomy has shown, whether it's in the coronaries or in the peripheral, is a reduction in stenting. So I think that if we can limit stenting with this, I got it. Can you show me a little higher? There you go. I'm at 30 now. I'll go a little bit lower. So if we can prevent a stent in this patient, it'll be great.
Well, PK, I was gonna ask you about that, but in this case, you've got a way distal DES and a proximal DES, so I think you have a pretty good idea of the size of the artery, so you probably don't need to do that.
Well, it would be nice if that was known, though. That's the issue. I guess that's where IVUS would help us, you know. I'm sorry, so a little bit of pressure.
And what is this, a 3.0, 3.5, 220?
So this is exactly that, Miguel, and it's funny because I know there have been a lot of opinions on tapering balloons. Some of us don't believe these vessels. It makes sense to have a tapering balloon in this situation. But, you know, it is what it is. We have a 3.0, 2.5, 210 tapered balloon. I think, Brian, you don't believe in this tapering stuff, right?
Yeah, I think they vessels change at bifurcations and across the ankle. I tend to use straight balloons. I don't think the diameter changes that much down at the ankle. Although I like how long these balloons are.
Yeah, that's for sure. So we're just going to leave it up for a few more minutes here. And, you know, I think the thing also is, I guess, how long do all of you leave your balloons up in these kind of cases?
I think that's
2 minutes.
Yeah.
good 2 solid minutes.
Solid minutes.
Clock 2 minutes. Not surgeon
Real the one, yeah.
So BK, this vessel doesn't seem that calcified. We had in the former live case from Leipzig this bullfrog technique. What do you think about that? I mean, would that be?
With the Mercator technology, you know, we find it. We've discussed it actually in Journal Club, and we've talked about that particular balloon. It's very interesting to me because, I mean, obviously inflammation plays a huge role in that, and I think it's very interesting to see how it pans out. If this comes back one more time, I think at this stage you have to give him some other options other than what we're doing. We were just talking before. He asked me a question: how many times am I going to have to come back to have procedures done? And I think this is a very frustrating part of it with these severe peripheral arterial disease patients. That's why I think that technology is exciting, as well as the other technologies regarding drug delivery into the vessel.
You know, there's really there's a couple of good papers out on the increase of the skin perfusion pressure by just adding xylostazol to patients. And so although it's a drug that's been, kind of guided for intermittent claudication, we've actually started to put it on all our tibial angioplasties in a way in which, regardless of if they go down, they're still increasing their SPPs, and it may keep them out of trouble. So there's also good data on stent patency and cilostazol also as being a factor, an independent factor that increases patency rate. So I think there's more to be said and probably hopefully more to be studied, but we're tending to putting all of our patients in cilostazol. I'd invite you to consider that because maybe if it goes down, if he has cilostazol, his SPP will be 20 millimeters above what it is baseline, and he may be out of trouble.
Yeah, I do the same now with not all of them, but anyone who's restenosed, Fempop or Tibial, I put them on cilostazol too.
Correct.
The other question is, as you can see, I balloon a little bit longer than most. The other question is in terms of antiplatelet therapy for these patients. Do you believe in increasing the antiplatelets? I know the guidelines say 30 days for peripheral intervention, and obviously for drug-eluting stents and balloons is a little bit different. But say you're just doing a balloon angioplasty without a drug-coated stent or a drug-coated balloon. Do you increase the duration of antiplatelets?
Yeah, I do, because I think the other thing you note from all of the trials is that as people progress, their mortality gets worse and worse, and that's cardiovascular mortality. That's not necessarily limb-specific mortality, so I don't think it's a bad idea to prolong it.
I think that's one key argument that that we should not only look at what's going on in the vessel, but also if they worsen, then they have more cardiovascular, a higher cardiovascular mortality, and even aspirin is reducing that.
Absolutely, yeah.
And what about, how do you handle dual this, because we're facing this more and more while we're watching the paint dry with the balloon. When your patients are on Eliquis or the NOACs, and they come to you for procedures, and then you have to restart them on, say you do a drug-eluting stent or a balloon, how do you deal with the NOACs? I mean, this is a question that we face. We have really no data to support it, and I understand it's all conjuncture and opinion and experience, but I'm kind of curious on you guys, because all of you have so much experience and busy practices. How do you deal with that in your patients?
Well, PK, I think you have to extrapolate again out from the coronary data. So that's somebody that would get the NOAC and Plavix instead of a NOAC and aspirin. That's just, you don't have direct data. You just have to extrapolate it out from the coronary data.
So what do you do?
So I do Eliquis and Plavix, or whatever, Xarelto and Plavix. I wouldn't do the aspirin necessarily, or if I did, there are rare occasions where I'll do dual antiplatelets and the NOAC for 30 days, and then continue them on on Plavix with the NOAC.
Yeah, with all three, the bleeding risk is high in the coronary world, and these patients are even, I think, generally at greater risk of having mobility issues and fall risk and those sort of things, which make that bleeding concern high. So I do the same. I'll either do one of the two antiplatelet therapies and then the NOAC.
So the Voyager trial is now going on, and hopefully enrollment has been finished, and so hopefully we will have within the next 12 months data on that, how we can go on in a safe way with endovascular procedure and NOACs.
I think because, in our patient population here, because of the use, we have a very busy atrial fibrillation program with some of the leading guys who do a lot of the ablations. We end up with a lot of these patients being referred to us who have this, and it's a real problem. The other issue also I want to ask, actually this is more to Miguel and Brian. The issue Flora, please, the wire's coming back. It's my mistake. Is that when you're dealing with a thrombosed graft, and say the patient is or I should say not graft, a thrombosed DCB site, which we do get. Do you go ahead and put them on Coumadin, or do you put them on NOACs? Because what we've also seen is we're seeing this phenomenon, I'm curious to see what you think, of this late thrombosis of DCBs, and they don't present with this acute MI type situation. What happens is they become claudicants once more because it's an SFA that's occluded, and then when you put your wire through, it just flies right down, and it's nothing but a column of thrombus. And then so what we do here is we check them for Plavix resistance, and then we find that they're Plavix resistant. So sometimes insurance, at least in America, won't pay for Brilinta, but they end up paying for a NOAC, so we put them on a NOAC and aspirin. So that's what I was going to ask you. If you have a thrombosis issue, I mean, do you guys still prefer Coumadin, or do you start them on the newer anticoagulation agents? Yep.
Got it. I'd say the first question is, is it really a thrombotic issue? I mean, I hear what you're saying about the wire sometimes gliding through these, but how, in those cases, I haven't personally experienced that. I've not had a DCB that I've treated, or a patient I've treated with a DCB that then acutely presented with a thrombosis or clinically looked like a thrombosis. They tend to be restenosis down the road. And those, if it was a true thrombosis, then that implies you're lysing them or using thrombectomy at the time of the procedure. Has that been the case for those?
Well, you know, we have lysed a few, but we've gotten very good at dealing with thrombus through penumbra and other stuff as well with aspiration.
So
So we
these are
do
cases-
we do power pulse and then aspirate and are able to get away with it. But this is true thrombosis, you know.
And when you clean them out, do you not find that there was some sort of dissection or any? No, it looks beautiful. You take the clot out, it looks beautiful.
It does. I mean, we're actually working on a series of our patients to actually submit, and that's kind of what we're looking at right now. But it's an interesting issue. I mean, I don't think it's very common, and by no means do I say that there's an acute or a problematic issue here. But we are seeing that.
But BK, I mean, if you say you have this huge population of AFib patients, and I would never put AFib patients back on Coumadin because we know that the NOACs are working that better.
Right.
These are the old patients. They have high bleeding risk anyway, so I would leave them on the NOAC and maybe switch to NOAC. I mean, that could be. We have, NOACs that work better and as others. So, I mean, I would never put back them on Coumadin.
Got it. Well, you can see here we did a couple of pictures. And I think you guys, we're all going to be very happy with this. It turned out that the suggestion by Miguel was absolutely right. You can see here, this is just a negative angiogram, forgive me. You can see here that the flow, once we were able to get rid of everything in that anterior tibial artery, looks pretty good. There seems to be a little bit of recoil right at around maybe the next one, maybe it's an overlap here.
It's like venous flow, maybe another projection.
Let's see what we're going to do. Right distally around 30, that's what I'm a little worried right there, Miguel.
Yeah.
But the flow into the foot looks really, really good.
Oh.
Wow, what a difference. Let me just try one other view here, just to just to look at that a little bit better. Shutter in, guys, for me.
That would have been a great profusor case.
Yeah, it would have been interesting to see.
You ready? I think we have a little X-ray issue here. I apologize. Ready? I think it looks pretty good. I'm just going to pull the wire back if you guys are okay with it.
You're funny.
That looks great.
And then just
Red case.
going to go a little bit into the foot and do a lateral shot of the foot to see what Miguel was saying.
Finito.
And I think Brian's suggestion to just leave it alone is absolutely correct here. Yeah. Yeah, I think that's, yeah, there you
I'll
go.
see the lateral plantar.
Much better. Look at that. That's much better. It's right at the base of the first metatarsal head. Sorry, sir, I know a little bit of movement. I apologize. No, nothing. So I think, over here, we're able to, I think we're just going to stick with just atherectomy and balloon in order to be able to get this open. I think that the distal dorsalis pedis vessels, we're just going to follow them along and see the wound. We have a good wound care center here, which we will go ahead and take care of it. And then we'll see how this wound progresses. I have a feeling, like all of you said, that it should definitely heal.
Put him on xylostazole.
The other question also, Miguel, is if we could have a perfusion, ability to see whether the perfusion is adequate or not. That would also
That would have been really nice.
really good here.
Yes, would have been very comforting.
That would have been very comforting to know when to stop.
Yes, sir.
So before I go, I wanted to show you the final pictures. I think you have to take the camera into that room to show the last pictures from room 4. the foot, the case that we did through the foot. So we had just done they have to come there to shoot it. They have to come there to shoot it. No, right here, right here. So that we did the calcified tibial artery from the foot up, and at the end, when Dr. Coombe was our moderator, and we were unable to actually, it's just the final runoff.
Oh, the 80, the one?
Yes, yeah, the final runoff. So we were unable to show the final picture. So let me just walk over there. Hold on, guys. Let me just walk over.
This is different.
So
First, yes, this one.
let me just go to the last picture. Thank you.
You guys can start closing that groin. I'm sure the team wants to go home, huh? Yeah, there you go. That's a smile.
Okay. Now I just wanted to show you the final picture. So this was the patient who basically had a non-healing ulcer of the foot and had the very calcified, occluded mid-anterior tibial artery all along here. So we got pedal access. We're able to cross from below using the Cook system. And through the foot, as you can see here, we'll cross in a second. Very difficult to get through. Stephen was there. We had to come with a wire from above, and then we're able to cross from below. Once we crossed, we did balloon angioplasty. And actually through the pedal system, because all we had was a 4 French pigtail from above, and through the pedal system, we were able to place 3 Zions, the new, what are they called again?
Zion Sierra.
Zion Sierras. And you can see here now we have beautiful flow into the foot. And then the pedal access site where we went ahead and put the 3.9 centimeter Cook sheath was phenomenal. So I just wanted to show you a final image of that particular picture. So I guess we're done here in the cath lab. So thank you very much for assisting us in this case. Thank you.
That was a great result.
Okay, that was
Nice job,
fantastic.
Pete.
Thank you.
Great, DK.
Thanks a lot.